Right. So next up, we've got Samantha Dell, who is a advanced clinical practitioner working in triage at the University Hospital Dorset. And she is going to talk to you about the role of the midwife in triage.
Yes, hi everyone. I'm just going to share my screen and give it a go. Hopefully this will work. Just trying to start it up. Can everyone see the first kind of screen? So my name is Sam.
Yes.
I am an advanced clinical practitioner midwife working in triage at University Hospitals in Dorset. And today is really about kind of taking you guys on a journey, discovering kind of what the ACP role can do, but also particularly in triage. And really kind of taking you through the trials and tribulations of kind of doing the training, doing the role, getting the funding, and hopefully throughout the day you'll be able to ask the questions that kind of were asked throughout my training. And hopefully will set you up to continue your training or your practice like I have. Let me just see if I can move on the screens. So, what is clinical practice, advanced clinical practice? Well, midwives and the multi-professional framework in England in 2017 set it out as advanced clinical practice is delivered by experienced registered healthcare professionals. And this level of practice is characterized by a high degree of autonomy and complex decision making. This is underpinned by the master's level awarded and encompasses 4 pillars. Now, I know Romy talked a little bit about the 4 pillars earlier, but I'm going to go into these a little bit more detail in terms of what that looks like in practice. So we've got the clinical practice, the leadership, the management, and the education pillars, along with the research pillars. And we need to demonstrate these core capabilities within that specific area of clinical competency. So what my clinical area of competency might look like is very different to someone who could be an ACP on delivery suite or in postnatal. So it's kind of looking at those specific clinical competencies and taking you through what my training evolved with. Now, their role embodies the ability to manage clinical care, but also it's a partnership between the women, the families, and their carers. And it's the ability to synthesize these complex problems, kind of, and also innovating solutions to enhance people's experiences. And that's what embodies the kind of the ACP role. It's that ability to give that holistic care. Oh, where's my little thing gone? So I thought this was quite a nice way of writing about the role. This is a nurse who's an ACP who works in an environment in ED, and she explained it in terms of how she would explain it to a patient. And I thought it was quite nice because I think it's nice to explain what an advanced clinical practitioner is. It's a non-medical workforce who are working at their top end of their licenses, pushing the boundaries of their scope of practice. But they are experienced practitioners trained to be able to undertake additional responsibilities safely, to assess, examine, and diagnose and treat and refer on when required. It's extend beyond their traditional boundaries of their roles, and that's what the ACP kind of embodies. So throughout your training or developing this role, you may have quite a few questions about kind of, will this be accepted by other midwives? What are the outcome and findings along the governance issues? And who funds this role? These are all the same questions that I had when I first started. So hopefully throughout this presentation, we'll be able to go and answer these questions for you, or well, at least start that conversation that you can then go back to your trust and ask your fellow colleagues. So A little bit about my background. I actually started midwifery in 2000. I did my training and qualified with just an advanced diploma in midwifery. I gained from 2003 to 2013 a lot of experience in high and low risk care, working within a consultant-led maternity unit, specialising in high-risk antenatal care, and that's where my kind of heart and passion came from. In 2013, I became the clinical lead for Triage and Antenatal Clinic, and developing the leadership and management skills through leading a team and through introductions of different projects like Triage and BSOTs. And in 2019, I started my ACP training, and we'll go through a little bit about what led me to that in a minute in terms of why I decided the ACP role was good for my fit. And then I commenced my accredited ACP master's course at Bournemouth University, and then achieved my MSc in 2022, and have been working in the ACP in triage for the last 2 years. And throughout the day, we'll talk about how that's evolved, what the outcomes are, and how effective the role can be. So hopefully you can join me on that role. So what can we additionally do? So people often ask me, when I was training, when I was in my leadership role, it was often quite frustrating that you'd see a patient, you'd have all this experience, but we couldn't necessarily step in and make the clinical decisions on patients that we knew what the outcomes would be. So it made me consider what would we need to do to be able to kind of utilize our kind of known experience in high-risk antenatal conditions and provide the women and the families with the care, with a robust review on a time frame that actually could improve their outcomes of pregnancies. We often found women were waiting long times for doctor reviews because they're often in theatre or in other kind of areas kind of dealing with other patients. And our patients then would kind of have these long delays. So it was looking at these issues and these clinical frustrations that led me to looking at the ACP role kind of in its entirety, really, because we had to answer the questions of how do we improve the patient outcomes. I looked to my nurses and companions in the ED departments, in neonatal practice, and started looking into possibilities of developing those roles in maternity, specifically within the triage. And I really felt that the fit for the ACP role was going to really benefit the triage department. So that's when I kind of presented to my matrons and my DOMs about the role, and they agreed that they should look into training, and that's when I started my training. So we recently have had a CQC visit. I'm not sure the trusts that are online may have also had this, but this CQC visit kind of asked us for immediate service development. It looked at the need that we need to improve in triage. It highlighted the fact that we still weren't meeting the standards for initial review. We needed to safeguard our staffing in triage because they kept getting pulled. Therefore, we couldn't then undertake the BSOTs effectively. And we had to try and improve our initial kind of contact from midwives from 15 minutes. We really were about 50% at that point, and we need to improve it to 100%. And also our medical review timings, we are at 23% in 2022 when the CQC came through. And we needed to then increase that. A CQC gave us a standard of 100%, so we had a lot of work to do. And it was then looking at how to achieve the seeming impossible task. I think having had this insight and the foresight and planning about the ACP role and starting that training 2 years prior to this coming through, I think that was helpful in terms of kind of pushing the role forward to actually get the ACP in practice. But it just came as a lucky kind of answer to this question, really. So we pushed the ACP into triage, and we continue working with that. But we had a big task ahead of us to try and improve our current standards with safeguarding triage midwives and safeguarding to improve the flow of that patient. We had to kind of safeguard the medical staffing in the area as well. So we had a big work task to do. So we currently, in our triage at University Hospitals Dorset, we have an average of about 5,000 births per year, maybe a little bit less than that currently this year. But our triage is run separate from our delivery suite. It's staffed by currently 4 midwives throughout a 24-hour period. And these midwives undertake the initial triage, and then they complete the ongoing care needs after that initial assessment. BSOTs, for those who use it or those that don't, you will be aware that maybe they have set times for initial midwife contact, and then that patient then gets color coded into different kind of color code needs depending on what their risk factors are. So there's red, there's amber, and yellow and green. Each color has a time frame associated with that, so they need to be seen either immediately, within 15 minutes, within an hour, or within 4 hours, and that's the red, amber, and green color codes. We interpreted the same requirements to doctors, which mimic the same color codes. So patient would require review either immediately, within 15 minutes, 30 minutes, 1 hour, or the 4-hour mark. But BSOTs has just recently changed that and have kind of removed the requirements for the doctor reviews. At UHD hospital, we haven't removed that because actually we've seen a vast improvement on our patient response and our review times, and the flow in our triage has improved with having these time frames, but we have lengthened them slightly to give us a little bit more leeway to try and hitting a little more of the targets, but not actually at the detriment of the patient's kind of care. So the only one that's changed is the hour. It's gone to 90 minutes to be seen within it, but it's still a time frame that we need to see those patients and get them seen as quickly as possible. So that is now working well. We have that staff and the covering of the 24-hour period, which is the new advance from our CQC. So a bit of background. So obviously we had to meet our growing demands, the service needs, and I think we know that increasing needs established, we need to innovate our care models and to develop the advanced roles that contribute to the workforce and transformation agendas. The ACP roles have always historically been developed because of being reactive to service response and the need to fulfill these service requirements. Whether that's right or wrong, it's what's happened. And historically, challenges to the education standards and quality and supervision, as Romy has highlighted in her presentation, there's been vast kind of challenges to the different standards, and how do we kind of move forward from that? And hopefully the NMC is coming up with those answers, which is a real kind of benefit for us. It's going to be a real kind of positive. There's lots of organisation governance, competencies and capabilities that we need to kind of ensure we meet. And it's really, really important to always have that job description, job planning and pay bands discussed and agreed when you are doing these roles. And obviously this has raised many discussions and concerns regarding professional and organisation liability of the practitioners working at this level. So it's really important that when you are developing or thinking about doing these roles, that you have these discussions and have these thoughts about these roles, because it's so important to make sure that you are working within your scope, but also within your job descriptions, because that is what's going to cover you. But having those discussions is the first kind of line to kind of moving forward. I'm just having to keep moving my picture around because I can't see what I'm writing. Why do we need to develop the ACP? So Health Education England states that having these healthcare professionals at ACP level increases the capacity and the capability within any service. Multiple research papers have demonstrated organisations, with these ACPs become a real flexible workforce. We meet the changing population and patient service needs, and it's actually, if you're kind of looking at it, it's a sustainable solution. We are midwives who want to train, want to expand ourselves, and we want to stay clinical. And that's a sustainable solution in terms of kind of long-term outcomes if we can get more of us kind of doing it. The ACP role integrates into multi-professional teams, and the ACP provides clinical leadership, which enables collaboration across teams and complex decision-making and management of the risk. I think having someone clinically on the shop floor with that leadership ability can really support the younger and the new preceptors coming through to make and help them make those complex decision-making practices and making sure they're making safe and effective care. It is really well evidenced that the ACP role can help improve clinical continuity and provide high quality patient care. And it's, you can look at different papers throughout since when advanced clinical practice started. There's a lot of evidence that proves that this is a good role for quality of care for patients. It also enables a workforce transformation and initiates a wide range of advanced clinical care. It provides a variety of and a range of professional clinicians rather than purely focusing on medical doctors as sole providers of advanced clinical practice. We can accelerate care for patients and improve their outcomes. If we see a patient, we can also refer on. It's not about making all the medical decisions, it's working as a team and ensuring that those women or our patients and our clients have the best possible care that we can possibly offer them. And working within that multi-professional team enables us to kind of provide that. Now, these are the four pillars, a little bit more in detail. So got clinical, we are an expert in clinical practice, and we like to advance our own practice. There's leadership and management, and that's advanced service provision, research and evaluation, and education and training development. And I kind of find over the 2 years I've been in the role that it's not that you would work in each pillar every single day. Some years you might find you're more clinically undertaking those pillars, or that next year are going to be more in research. So it's very fluid in terms of kind of where you sit with those four pillars, but it's making sure that you actually undertake a lot more of the four pillars than is in normal practice. But you find that you will probably sit in the clinical and maybe the education or the leadership more than kind of the research. But it's about looking at the four pillars and making sure that you are encompassing all that it means as an advanced practitioner. Why do we need the multi-professional framework? Well, it ensures national consistency and a common themes. It gives us an understanding and how the practice can be deployed and how we can ensure that there's better patient care. It also gives us the opportunities for career progression. I often found that when I was training and when I was in my leadership role, that I didn't really want to move on in terms of management at that point. I wanted to stay clinical. I have the passion for clinical care, but there wasn't very many opportunities to develop that self into that area of clinical expertise. And this job role gives us that opportunity for ongoing career progression, ongoing learning, and developing that knowledge and advanced skills that will essentially provide much more effective care for patients. The framework has developed area-specific advanced practice capabilities and patient care and service delivery needs. So it's really, really important that you look at the framework when you're developing the role to look at how it's going to effectively kind of support you through it. It also enables local governance and arrangements for safe and effective practitioners in their own workforce. Obviously, with the NMC exploring different approaches to regulations, that's a welcome added part of the revalidation, and obviously that's going to be posed hopefully to start in 2025, 2026, but that's going to be a real welcome kind of addition to us, because I think throughout the last 2 years regulation governance has been a big question about how we providing evidence of how I'm still working at advanced practice level, having supervision, how do we provide that, and how do the trusts know that that's what we're doing. And having this being explored by NMC is going to be a real really positive approach for us moving forward with the ACP kind of roles. So that's going to be really, really good. So what does the clinical pillar look like? So training and assessment. So During my training, we looked at advanced history taking skills, utilization of consultation methods, critical analysis, which is we spend a lot of time looking at how you'd critically analyze research and what that looks like in terms of kind of providing that care that we then give. It also talks about, it trains us to systematically assess a patient from top to toe, looking at the general kind of outcome of the patient. We can then test glands, cardiac, respiratory, abdominal, neurological, MSK, full assessments. We can request diagnostic tests, developing the knowledge and skills and interpretation of these competently through the clinical pillar and through the clinical education that we've had with our set skill standards. Throughout the training, we're tested on this, we're assessed on this, and effectively kind of backs up our knowledge base to be able to undertake these assessments of a patient's clinical and needs. During my training, we had area-specific training needs, and we identified them. Potentially, you're going to be watching and seeing people in preterm labour, preterm with cervical problems, cervical changes. So it was highlighted to spend some time in colposcopy, in preterm birth clinics, looking at cervical scanning, and reviewing and observing abnormal cervical findings. Because actually, we may be examining patients who have got abnormal cervixes, and what do we do with that information? It's about kind of identifying it, requesting and diagnosing it, but also referring on to people that are outside of our limitations and knowing those limitations of what you've got. I've observed the LETS treatments, the cone biopsies, along with other abnormal findings such as polyps and cervical endometriosis. So all those kind of experiences within this kind of training needs has been optimizing my experience now in triage. Spending some time maybe with the maternity physio, assessing vaginal prolapses, caring for identifying bladder retention, pelvic floor issues, bladder scanning, having all that training and assessment for that to be able to undertake the scans, and other MSK issues in pregnancy, and how do we effectively diagnose it, how do we effectively treat it, and how do we give those women the support for that. I also spent a lot of time within fetal medicine, developing greater physiological understanding behind fetal growth restriction, abnormal Dopplers and how Dopplers kind of indicate placental well-being, and to provide improved ability to review the scan results and plan care effectively and safely for our patients. Maternal medicine clinics also are exceptionally helpful in reviewing patients with medical conditions to enhance the understanding behind the conditions and how they relate to pregnancy and how we would treat them or sustain them throughout their pregnancy. We've also done the non-medical prescribing qualification, which really kind of, I think, ties in everything together in terms of being able to effectively assess someone, work through our clinical diagnosis, and potentially kind of give them the treatment for that, working through logically and effectively. Always using NICE guidance and CKS guidance in terms of diagnostic tools that we could utilize. So it's always using those methods of critical and analysing the research to base our formation of our clinical decision making. So essentially that is what the training pillar of the clinical assessments looks like. It may differ in different trusts, but that is essentially kind of what that clinical pillar looks like. So the leadership pillar, I really feel that provision of leadership is as an ACP is on that front line. It's that frontline leadership on the shop floor, presenting that support, and showing midwives and care assistants best practice. So I really feel it's really important to kind of undertake the leadership pillar. It improves in communications between patients and the multidisciplinary team, assisting in the recruitment and retention by addressing the skill gaps in the clinical practice. It also ensures midwives have a sense of support and are encouraging to enhance their own knowledge and skills through the clinical practice. We also assist staff in management of complex patients through clinical leadership, supervision, and this clinical leadership influences staff of all levels to improve basic clinical skills, and also improve triage outcomes by making positive culture changes to the perception of the ACP and what the role can achieve for both client and staff alike. So that has been kind of the journey of my leadership kind of pillar, because obviously when I first brought in the ACP role, no one really knew what it was. They were a bit kind of apprehensive about what the role could achieve for them. They were worried that we would be kind of doing their job for them. So it's about kind of using that leadership ability to communicate, to positively change the culture and the perceptions for everyone who's involved on the shop floor. So for me, it's about this education pillar is about getting back to basics, back to basic education for support and staff of all grades, but also utilising the advanced skills to demonstrate best practice influencing that next generation of midwives. It's about utilising what we do now to influence what they're going to do in the future. And I really, really feel that this role is really kind of well placed to do that. We're obviously developing education opportunities, talks like today, in clinical practice to enhance understanding regarding basic care principles. So also this would improve that provision of patient care in like history taking techniques, clinical skills, like presentation scans, support with spectrum examinations, ECGs if they need to kind of have a little bit more understanding about that, if that's what they want to go on and do. Teaching university, I have the opportunity to undertake some teaching to student midwives in clinical care, teaching about the ABCD approach, history taking techniques, and anatomy and physiology of observations, which I feel, like I say, get back the basics and teaching from that shop floor really kind of gives them that kind of real personal touch. And also my own education and learning is yearly. I have clinical supervisories, utilising case reviews and clinical patient assessments along with self-reflection within the 4 pillars. And this will obviously become more effective with the NMC kind of hopefully kind of route to regulation. Life learning and development skills, which is not just in the ACP role, but in midwifery in general. But we are looking to always continually improve our patient care and experiences, especially in our triage setting. And if we can do this through development of personal education standards and then patient education and staff support, then eventually that holistic care will become a lot kind of more standardized. Research is the why, the who, the when, and the what to my practice. So healthcare is consistently changing with evidence-based practice coming through all the time. And as ACPs, we need that research capability to understand and to ensure best advice and evidence can be used for the patients. The ACP training gave us that kind of training in terms of being able to look at research and critically apply research findings to practice. And this kind of is our backbone to kind of guiding staff and patients through things like policy writing. It requires skills gained through master's level to look at research and identify relevant literature, evaluate its quality and interpret results. And gaining this advanced understanding, it kind of improves the strengths, weaknesses, and essentially identifies biases in literature that we can then avoid when we are passing this information on. It's not just about kind of reading the research, it's about becoming part of the research as well. And I think, I think in these roles, or any role in midwifery, research is a real kind of important part to be in. And I think, I'm certainly learning that now. And in the next kind of 12 months, I'll be taking on some hypertension studies as part of a more national research in terms of improving patients' outcomes, which is all what the research is all about. So it's a really important feature, but you may not, in part of your pillars, be doing it every single day. But it's certainly that's something you need to kind of consider when you're doing your ACP role. And why is it the ACP role and not a specialist midwife? Well, we are able to provide that systematic review, the holistic assessment of patients, consider, evaluate, and for the differential diagnoses. The difference is that we have the ability to work across subjects, looking after patients completely, rather than just in one condition. like maybe diabetes, or kind of maybe fetal medicine. And that's what the difference is between the ACP role is I'm not a specialist, because we can work across all subjects. We have that kind of advanced clinical knowledge about everything that we're doing within our specialised area. Ultimately, I can, we were talking about earlier about requesting diagnostic testing, scans, ECGs, and these will require a systematically approach to the patient conditions. So it's really important to kind of understand that the ACP, although we're specialistic within the triage area, we are advanced in our knowledge, and we can review and undertake care on a wide range of patients, not just on that specific kind of that role. So what does my job description look like in action? So I can undertake reviews of all conditions presenting to triage. I can, along with the MDT involvement, I can refer, review, and refer on to appropriate resources. So if I needed someone to be reviewed by a medical team, then I can refer them on to a medical doctor. But ultimately, I would very much closely work with my registrar, my consultant on call, and run any reviews through them to make sure that actually that's the right clinical decision to be made, and get second opinions whenever it's needed. I'm not working alone, I'm working within the team environment. And it's really important to understand that I'm not alone making these decisions, but ultimately it's doing that work upon that patient. I can view patients with hypertension, headaches, visual disturbances, PET symptoms, abdominal pain, sepsis, interpretation and action of blood results and microbiology test results, which can often be really important to make sure that that communication with that patient's there. We're happy to vaginal bleeding from 14 weeks to 28 days postnatal, preterm ruptured membranes, pre-labor assessments, postnatal infections, mastitis, the whole kind of shebang, really. Everything that's coming through triage, we're able to review, we're able to assess, and we're able to refer on and make those clinical decisions for them. I can review abnormal scan results, fetal growth restriction, abnormal Dopplers, polyhydramnios, oligohydramnios, and that reduced fetal movement pattern of patients, and making those ongoing plans, looking at the holistic care of that patient. CHG is not meeting criteria, but also working alongside, and like I said, I'm part of the MDT team, making sure there's collaborative working is undertaken. I think when you work together as a team, that's when the best outcomes for these patients can happen. I can advise inductions of labours after discussion with my senior colleagues, but having access to my senior colleagues to make that collaborative decision is essential, and making sure they understand that you will be going to them to have those decision making. So generally, everything that's come through triage can be seen, assessed, reviewed, plans made with collaboration if it's required. So that's why the role can fit very, very well within the triage kind of area. I seem to rattle through that very quickly. Is there any other questions that people might have? I'm happy to obviously go through that a little bit more in detail, but I'm happy to kind of take questions if there's any questions there.
Thank you, Sam. Yep, we've got 2 questions. There'll probably be a couple more come through as we speak. But and the first question actually will be interesting to hear you answer, and then I think I'll ask our next speaker the same one. So it's how does your ACP role differ to what an SHO would do in triage?
It actually doesn't differ massively. I am, like I say, in terms of my ACP role, I'm not a doctor. But I can undertake the assessment, the history taking of a patient, working through what they're telling me, working through their differential diagnoses. We're utilising the CKS, a nice guidance, talks through different differential diagnoses of a condition. It gives us that support to think about, have we looked at this condition? Have we looked at this idea? We can request blood tests. We can undertake those blood tests and review them. So actually the role doesn't differ very much in terms of what an SHO can do. It's just that we I don't know. I think the difference is we are experts in the triage, that we live and breathe it every single day. And I think where it comes, they have a lot of experience medically. We have a lot of experience with pregnancy. And I think where we differ is sometimes we can work collaboratively together. So I might work up a person with abdominal pain that I'm thinking it could be appendicitis. And then I maybe collaborate with my SHO colleague to say, this is my concerns, these are my workings out, this is my findings. Is there anything else that you would add to this? And it's about working to everyone's expertise rather than trying to be an expert in something you're not. But it's not about being different from them. It's a different role, but we are able to undertake the same kind of assessments as an SHO.
Perfect, thank you. The questions are actually coming through thick and fast now, and I haven't had a chance to read them all. But I'll go through them. And so I think according to the agenda, we're due to start the next speaker at 10 past 10. So we've got 10 minutes for questions. So we'll get through as many as we can. There are two questions that are similar. One is, are you the only ACP? And then the other question is, how many ACPs work in your triage?
So yeah, I am the only ACP at the moment. Obviously, we've only been going really kind of 2 years. Yes, we are. I think there's a hope or a wish for more to join the team, because that would be ideal to have a team of us that we can run it 7 days a week. I cover the service 4 days a week at the moment, and I'm on an 8 to 5 basis, or sometimes maybe an 8 to 8 basis. But I'm not there 24 hours a day, 7 days a week. And that would be the utopia in terms of having someone there. So when I'm not there, there is an SHO within our triage department, kind of 8 till 5, and then kind of overnight. But yeah, it's a work in progress, and it's a new role. But yeah, I am the only ACP at the moment.
Perfect. And then someone's asking, who takes on the role of your supervisor?
So my supervisor who's going to be talking in a minute, is Abby Languish. She is a obstetric consultant. We do our clinical supervision together. I also have fortunate to have 2 consultant midwives, and I have supervisories with those as well. So I have the best of kind of both worlds in terms of an obstetric perspective, and also from a midwifery perspective in terms of advanced clinical practice.
Perfect. And are there any competencies for your role?
So when I went through the training, it was a case of kind of looking at the role specifics and looking what we needed. So we developed our own competencies, and this is what the NMC is looking to develop along with the kind of what is required, and we're working with them in terms of looking at specific competencies for each area. So I looked at what I would be reviewing and what competencies I would be required for that. So looking at kind of your speculum competencies, your abnormal cervix findings, prescribing, scanning, all the different competencies that I would be required to do in this area. And we kind of went with that. But I think as time's going on, more competencies will come through. But that certainly is what we started with.
Perfect. And then somebody's asking about succession planning. Is there any succession planning in place?
Yes, certainly we're trying to kind of look at funding. Funding is a big thing that we talk about in the whole of the day. And it's looking at the ability to train more people. We have got one more ACP in training at the moment. And it's looking at kind of continuation of development of that training into these roles, so that we can, one, have a team of people, but also have that succession of the ability to kind of keep training people up, so that actually it becomes a normal progression of the role rather than just one person doing it.
Perfect. And somebody's asking if you have an obstetric physician at the trust and a separate maternal medicine team. If so, do you integrate with them, and do they work in triage often?
We have a physician's associate who will do the occasional day in triage. We have a fetal medicine team, but not a fetal medicine ACP. Like I say, this is quite a new role for UHD, and I'm the only ACP at the moment currently working in UHD in maternity. We have a vast array of ACPs in the main trust in ED, medicine, cardiology, and ultimately utilising their knowledge base and their experience throughout my training has been kind of crucial. But yeah, so I'm the only one that works in triage at the moment with the physician's associate, but we are looking to develop more, I feel.
Perfect. And a couple of people are asking if you would be happy for your contact details to be shared, as people want to link up with you.
Absolutely, yeah. I think one of the last time we've done this, we generated a lot of people coming to talk and kind of emailing and collaborating. So yeah, absolutely happy for it to be shared.
Perfect. And somebody's asking if you yourself can perform growth scans or cervical length screening.
I can't at the moment, but that is my next step, which I would be wanting to learn is growth scanning and cervical length scanning. I feel that's a real beneficial kind of thing to have. But going through the ACP training, that was an extra couple of years on, and at the moment I need a little bit of a break from education and training. But that would be my next kind of probably next step on to make this role even much more effective in the triage department.
And then there's a couple of questions asking something along the lines of in most triages, there's clear pathways for what can be a midwifery discharge and what needs to be a medical discharge. Is there a clear pathway for the women that you can discharge without medical oversight?
Yeah, so I think in terms of clear pathways, I think whatever medically needs discharging, we can do. If an SHO needs to do a medical discharge, so can the ACP. But I think it's really important that even with these kind of protocols and these guidance, that if you're not sure, that we kind of refer and ask and bits and pieces. So there's a lot of things that I can see, like abdominal pains, UTIs, hypertensions, abnormal scans, abnormal CTGs that we can review. We can look at the whole care and then make that ongoing plan and discharge. Yes, that is very much within kind of that scope of this practice. But ultimately, there's always someone that we can refer it to if we're not sure.
Mm-hmm. So then somebody's asked, is the ACP Masters a 2 or 3 year course? So I can say that it's a 3-year course.
Yeah, so mine was a 3-year course. I did mine in Masters. There are different routes you can take down as a apprenticeship route. I do think they're all about 3 years.
Yeah, that's my experience as well. And then someone's asking, when you are in triage, do you have an SHO or a registrar working alongside you? And how does it work in terms of funding?
So when I'm working in triage, I am the ACP in triage. We have a on-call registrar and SHO who are on our central delivery suite, but not specifically for triage. But we definitely have a registrar or a consultant on call that we can always go to and work within. And in terms of funding, now there'll be a lot of discussion about funding throughout this day, and we'll talk you through kind of what that looks like in terms of the funding. But I am currently funded on the medical budget. As when I qualified, there was no funding within the midwifery budget for my role. And I was really, we needed to make that decision and make that change because of our CQC review. So I was fortunate enough to be kind of funded by the medical budget. Whether that's right or wrong, that will generate a lot of discussions later, I feel, on the day. But it is what we had, and that was the best option at that time. There's pros and cons for everything in terms of funding, but when you are developing this role or thinking about it, funding has got to be the very first question you ask. When I start this training, who is going to fund this role when I get to the end of it? Because 3 years goes very quickly and funding goes every year very differently. So I think it's really important that you have those discussions with the DOMs and the HOMs about the medical budget and about the funding and about who's going to pay for this role at the end of it, because it's really, really important to have those discussions from the onset.
Yep, I agree 100%. And then I think one last question, which I don't know if you'll know the answer to. I think it might have been better to have asked it to Romy. So actually, if you don't know the answer, we can always forward this to Romy because she's left the call now. But it's if you already have a master's, is there a conversion option?
I don't know.
Yeah.
And when we find that out, I'll be interested to know myself.
Yeah.
Because in terms of masters in advanced clinical practice or just a master's, it would be my answer. And what you want to convert it to, is it like a master's in something different? I don't know. But yeah,
Yeah.
I don't
I
know.
think it might be it was Fiona that asked that question. I think Romy said that she's happy for her email to be shared. When I get hold of it, I'll see if I can and give it to people, and then I would email Romy and ask her because she's the person that would know the answer to that question.
Brilliant.
And then the one last question. Oh no, there's more coming through. um, someone. Oh, Fiona's saying she already has an advanced practice degree. So yeah, that would be Romy that needs to answer that question. Um, yeah, and then there's some more questions about how the qualifications work. So it is tricky because at the moment, so the main way is you do the master's, an accredited master's in advanced clinical practice. And when you complete your master's in advanced clinical practice, then you are qualified as an advanced clinical practitioner. But that pathway is relatively new. It's only really been the last few years. So midwives that went through the pathway and were working as advanced clinical practitioners over the last 5 to 10 years had to go through the e-portfolio route. So they had to provide a portfolio and get it signed off to show what level they were working at, what qualifications they were. And then they have been able to get a digital pass confirming that they are an advanced clinical practitioner. So there are different routes. The easiest route now at this point in time is to do a master's in advanced clinical practice. But yeah, I think if we get Romy's email address, and then people can email her directly and get questions.
Brilliant.
Right. I think that's it. Oh, and someone's asking about banding. So, according to the Agenda for Change, a qualified advanced clinical practitioner should be paid at an 8A role.
Yeah.
Yeah.
And that's certainly what I'm paid at. I think most trusts, in terms of the Agenda for Change, that's kind of what they are, and that's what that's the issue with the funding. I think in terms of the 8A, I think it's a big difference between a 7 and an 8A, or not in terms of pay, but I think in terms of the funding and what they see it as.
Yeah.
But I think, yes, I'm certainly an 8A, and that's what we should be paid at.